Welcome to Good Tech, Compassionate Healthcare, an AMS healthcare podcast that explores the convergence of technology and compassion in healthcare. We host conversations between leading researchers, scientists, and healthcare providers as they confront the challenges threatening our current and future healthcare system, especially in the face of the pandemic. We see an incredible opportunity for digital health to innovate medicine and clinical care, healthcare education, home care, and beyond. That said, we hope to foster an open-ended discussion about how to integrate technology into the healthcare system in a way that enhances and doesn't diminish compassionate care. Ultimately, improving the experience of patients, caregivers, and healthcare providers alike. If there was ever a time to uphold compassion as the bedrock and guiding principle of healthcare, it's now. Join us now to explore Good Tech, Compassionate Healthcare, brought to you by AMS Healthcare. Today's conversation focuses on how digital interventions during COVID impacted the way we deliver compassionate care and features David Wiljer from the University Health Network, as well as Jillian Stredwick and Allison Crawford from the Center for Addiction and Mental Health.
I'm David Wiljer, and I'm joined by my colleagues, Dr. Jillian Stredwick and Dr. Allison Crawford. And we are going to introduce ourselves, and then we're going to have a little conversation with you today about how digital interventions during COVID might impact on the way that we deliver compassionate care. I'm David Wiljer. I'm the Executive Director of Education Technology Innovation at University Health Network and a professor in the Department of Psychiatry at the University of Toronto. And over the course of my career, I've been very interested in the intersection of education and how we can both educate our patients and engage in education with our patients, as well as work with our healthcare professionals to use technologies to deliver care. And it's struck me throughout my career that the use of technology is really driven by this need to improve our practice and improve the way that we're working. And I'll start with a story that has inspired me in my career. So early on, I got the opportunity to work with Dr. Kevin Leonard, who was a real champion of patient access to the health record. And he used to tell a story about going for an appointment for an ultrasound. He was very open that he had Crohn's disease and he was a real patient advocate. So he went for this ultrasound one day, and at the end of the ultrasound, he was going to an appointment. As he was leaving the room, the technician took his report from the session, folded it in half with the text on the inside, and then stapled it all the way around and handed it to him and said, "Here's your document. Go ahead and bring this to your physician." And he said, "Well, why did you staple it? What are you doing? What am I, hard of opening staples?" The technician said, "Well, I'm not allowed to show this to you." And he said, "But it's mine." So as we talk about the digital use of technologies for compassionate care, for me, I've always been inspired by that story of thinking about how do we, in a digital way, undo those staples? How do we think about the way that we create a constructive conversation and really assist in the way that we open up that communication? Throughout my career of thinking about patient portals and access to information and helping people use the technology, I think compassion has been a true north, and we'll talk a little bit more about that as we go forward.
So my name is Jillian Stredwick. I am the Interim Chief Nursing Executive at the Center for Addiction and Mental Health, and I'm a scientist with the Digital Mental Health Research Lab here at the hospital. My story as to how I became interested in this space goes back to when I was a nursing student. I had the opportunity to have a part-time summer job at a factory in Peterborough, Ontario. And it was a factory that produced food, so not in the healthcare space at all. But I was paired up with the occupational health nurse and took every opportunity to explore the factory that summer and witnessed and observed the use of technology doing things like checks and balances, having data drive how quickly or how food should be produced at what rate, in addition to the use of robotics. You can imagine when I went to my first clinical placement at a hospital in Southern Ontario and witnessed stacks of paper, no computers in the nursing station at that time, not that long ago. So you might say, well, that must have been a while ago. No, not that long ago. I was concerned about two things. So one is missed care. So we had paper cardexes. And for those of you who remember paper cardexes, those were essentially what you had to do for the day. All the essential care was listed on those paper cardexes. And I was very concerned these were written in pencil. And we had checks and balances in place for the night nurses to check all the orders and make sure they were up to date. But I was quite concerned about missing important aspects of care. And then the second piece that I was worried about was that we had accumulated a lot of data through the records, so through the charts, and that these were on paper and very difficult to aggregate. And so I thought, well, if we could pull all this data together, we would solve some of the great sort of medical challenges of the day. Fast forward to now, not so easy perhaps to do, but we're making a lot of progress now. And to me, being able to provide compassionate care is about being able to leverage technology, not to focus on technology, but to leverage technology to be able to provide safe care and to provide care that is evidence-based and that we're using our data to inform care. That's been my journey to this space.
So my name's Allison Crawford. I'm a psychiatrist and clinician scientist at the Center for Addiction and Mental Health, where I'm also the director for virtual care. And I also organize outreach, so both in person and through virtual care. And I think that contrast, I've been organizing in-person outreach, so fly in to underserved locations across Ontario and in Nunavut for many years now, at least 10 years. And virtual care emerged as part of that for me. So I've always had that contrast brought to the fore of the differences between working virtually and working in person. And thinking not only, so I provide clinical care there. I've lived and worked in Nunavut and provided clinical care there. But then thinking about how to develop a health system, how to do that. On one hand, when you do administration, it's how do you be efficient and how do you think about quality of care and all of those things. But then when you also have to do the clinical work, that therapeutic relationship with individuals and then with the community, you know how important that is. So I've always thought about, as we transition into a more of a hybrid model of in-person and virtual, how do we continue to pay attention to those relationships? How do we have relationship-based care? And it was only in starting to work with you guys, I always thought of it as sort of empathy. And then as we've evolved our conversations and joined this larger conversation about compassion, thinking about that difference, that it really is being with. And so how do you be with not just individual patients, but with communities and think about their spaces and their values and what's important to them? And how do you keep people feeling empowered even as you're providing care at a distance? That just has always been very real to me. And I think about one young man that I worked with in Nunavut. I could think of so many stories. And I feel like constantly these, when you think of transformative learning, constantly these individual stories, things that you encounter, challenges that you encounter can be a bit disorienting, give you those disorienting dilemmas, but also then change your thinking around something. So this is an example of that. I was working with a young man. I call him a young man, but he was 11 or 12 in a community in Nunavut, and he had thoughts of suicide. We had nowhere to keep him in the community that was physically safe, and he ended up in having to stay in the jail. I had just finished a whole dissertation on the impact of doctors and the healthcare system on people in Nunavut, and was really aware of my role and how keeping someone safe feels compassionate and necessary, but also had all of these unintended consequences. And I worried about all of those harms. We managed that situation and there was no perfect management of it. But then I had to see him through virtual care in follow-up a couple of weeks after that, once I had left the community. that made me really think about other spaces. So the space of a jail is obviously not a space of healing. And it just made me it made it more salient. What is this space of virtual? Could I be really connected to this person and to his local context, even though I had been there? So that was one, maybe an example on the extreme end, but made me think differently about virtual space and how we can be compassionate, or challenges about being compassionate in virtual care.
So this notion of digital compassion, as each of you tell your stories, there's this underlying idea that somehow care is different when we're thinking opportunities. And we first started together talking about this notion of compassion in the digital world. I think we were not quite sure how the conversation would be interpreted, and people really, including all of us, have leaned into this conversation and trying to explore and make sense of it. Gillian, I'm wondering, as we started to talk about this, if you could share a little bit about why this resonated with you, and what does digital compassion or caring compassionately in a digital world really mean to you, and why have you embraced it and worked with it as an idea?
I like what you said, David, about thinking about different opportunities that virtual brings or digital brings, because I think that was really the hook for me that got me interested in this space. I think about a time when I pulled out a laptop and started using it in a way with a client that I was caring for that got to something that we couldn't do in, I was going to say real life, but in person. This individual was looking for an apartment. He was an individual that couldn't leave the inpatient unit, and I can't recall the specific reason. Maybe he was on a form at the time and didn't have passes to go out into the community. Looking for an apartment in an expensive city, in parts of the city where he wasn't familiar, and knew that the neighborhood that he wanted to live in was quite important. So having access to a bus stop, a drugstore, a library, these sorts of things. And pulling out that laptop, we were able to look up the neighborhoods in which these apartments were located and do virtual walking tours to see if they had the things that he was looking for. And for me, that was about using technology in a different way. And so again, not focused on the technology per se, but on what it allowed us to then be able to do. And what I found it allowed us to do was connect at a different level. It opened up all these other stories. And then we spent the next little while actually talking about different aspects of his life to date and bringing up Google Images to share what the environment looked like as he was sharing those stories. That was really the hook for me. That got me interested.
And I love this idea, and it's come out through some of the work that we've done. A lot of this is changing the way that we think about space. You brought a place and a space to that particular individual. It changed the conversation. It allowed you to have a conversation that you may not have been able to have before. And Allison, that came across, this transformation of space. I mean, your story that you told as well, and how important space is, and maybe the opportunity to use digital to transform the way we think about it. So
absolutely. That's exactly what resonated for me in that story, Jillian, that one of the barriers I have found or been sensitive to is the potential erasure of space and locality and community through digital. So totally excited about increasing access to healthcare available through digital, but aware of this potential limitation. And it strikes me that how much extra you had to do, that actually was a compassionate act. That wasn't inscribed anywhere in any kind of protocol, or you just thought about doing it. And you were both lucky to encounter each other. It sounds like he expanded your world as well. But how do we move that from compassionate individuals who are creative and can connect with somebody and therefore attend to those things and bring alive space and meaning? I would say spatialized meaning. How do we bring that alive as organizations and in our planning? I think that's a bit of an uncharted, no pun intended, but I think that's less clear. Just having rooms where we flip on computers and have access to people probably doesn't encode those practices in a way that we would like on a more systemic level. So I think, teaching is one way. How could we teach people to do those sorts of things and think about people's lives processes and policies. So I'm now thinking about even something simple, but yet important, like doing land acknowledgements. How do we do that in virtual space? We've really changed our practices around that. You want it to be meaningful. And we've even started talking about space differently and how do you make virtual space safe for people, psychologically safe, culturally safe. I think those are necessary foundations for compassion. So keeping that space, keeping an awareness of the space, and then keeping the space that you do co-create, that's virtual, keeping it safe.
And when I think about space and the space of caring, often I think people feel comfortable about four walls of space because it creates boundaries, and you can have a door and you can come out and you can manage, the way that interaction happens, and you can set up the space in a certain way. And we can do that from a digital perspective, but we don't necessarily know how to. And I'm reminded of an experience that a therapist shared with me of working with a young person who, again, was experiencing suicidal ideation and was really struggling. And she was struggling and having trouble sleeping at night, not knowing how this person was doing. So she started to text him and just send a message of, "Are you okay?" And send back, "Yes, I am." And that seemed to be a connection out of the normal space that helped them. But at the same time, that creates all kinds of issues around what are the boundaries of care? What are the expectations? What if the device doesn't work one day and you can't respond? And so this notion of the competencies of creating that digital space, I think, are so vital.
If you find this conversation interesting, check out the AMS Healthcare best-selling book, Without Compassion, There Is No Healthcare, where 28 outstanding Canadian healthcare leaders confront the challenges threatening our healthcare system. Find it wherever you buy your books. Now back to our conversation.
This topic is very interesting to me because I think one of the things that is happening in a lot of entry to practice programs, whether it be nursing or medicine, pharmacy, or many of the different clinical programs, are the entry to practice level competencies for just using digital technologies. And I use that term very broadly because sometimes it's specific to, say, an electronic health record. Other times it's looking at apps and how do you engage in conversations about those, it being so broad. What I think we're still figuring out and then yet to implement into, say, curriculum is what are these competencies that healthcare providers need to have to be able to engage in these sorts of practices in meaningful and compassionate ways. The work that we've been doing is we've been starting to get at that, to trying to figure out what are these. And some of them are the basic principles of providing compassionate care. Some of those are foundations that we'll have to continue to build upon. And I think there's others, though, that may be technology specific. And some of it may be if we're in a virtual care session, which I know I'm looking at my colleague here, Dr. Allison Crawford, who does a lot of this work, but setting up ahead of time when you go into a virtual care session, if the connection ends, what's our backup plan so that we can still continue on with this dialogue and that we don't completely drop off the conversation. And so there's lots of little things that I'm thinking of that could be incorporated into teaching students right now. But I don't think we fully know all of the different pieces yet. So I'm excited to learn more and to work with you both in identifying those.
One thing that Gillian just said that really struck me anew is that, when we say digital compassion, it's so easy to think that we just mean people and feelings. It almost feels like a feeling word, not quite empathy, but this idea that technology itself can be used and can have features that are compassionate. So, and the idea of when you use the word connection, that connection, yes, it is the relational connection, but it also having a good connection, digital connection facilitates that. So there are human factors and there are technical factors as well that contribute to compassion.
And just like in person, we also can have the messy bits, the awkwardness in the digital world. And somehow those awkward moments of losing your connection or somebody getting frozen on screen, that can amplify the anxiety that people have around building that relationship. And yet it can just also be a moment where people embrace the messiness of it, and people have to have varying degrees of comfort of that. I do love this idea as well of thinking about what really constitutes a compassionate technology. One of the things that I've been interested in is this idea of sharing information with one another and with patients. This idea of helping the relationship through transparency. And certainly in the last couple of years, we've seen the importance of this. But the notion that we would in real time share information as it becomes available can be daunting from a clinical perspective. And over the years, I've had many people voice the concern that we'd be doing harm to our patients by sharing information that we don't somehow control of how we share that. And yet we hear patients say over and over again that that moment of not knowing, of not having that information is so anxiety provoking.
Well, this immediately reminds me of a Seinfeld episode in which Elaine, if anyone recalls that, in her doctor's office, there's a paper chart there. The doctor leaves. She opens up the chart and sees that it's written that she's a difficult patient. The doctor comes back in and she confronts him on that. And there's a comical sort of dialogue about whether she should have seen that note or not, and whether he was going to erase it and all of that. And so fast forward to some of the conversations we're having now, where sort of the wheels are greased in providing access to medical records, often through a patient portal or some sort of digital means. And for some, this is really anxiety provoking. When I say some, the research so far has shown us predominantly on the provider side, that this has been anxiety provoking. And much of the literature also shows that when these sorts of technologies are implemented where you're sharing notes, things tend to be okay. Folks tend to receive the information well. But it's certainly an area within, when we think about the mental health context, where this is not yet commonplace. This practice is still fairly situated in just a couple of organizations. It's gaining momentum. We're still looking to see about how can we build that comfort level from all perspectives, from those receiving care, those providing care, and those that are in caregiver type roles. What does that need to look like? And I don't think it's just simply opening up the record and then let's go. There's likely a phased approach or a helping each other get comfortable in doing so. And then the big questions are, should everything be accessible? And that's a question that I think we would need to have a robust conversation with an ethicist and legal folks and patients and physicians and other care providers to even get a sense of all the issues that are thought about there.
It reminds me of a troubling dimension of compassion, or at least one for me that has a bit of residue, which is that it could potentially be experienced as patronizing or as sustaining a power differential. You know, there's something about the history of the humanitarian type history of compassion that you're bestowing this on somebody. And what you're talking about, Gillian, it has the potential, I think, to reverse that, for people to have autonomy and to be empowered and to own their own health data and be able to access it. That's a different kind of compassion, one that I can get behind a little bit more easily. You know, so when we think about elevating compassion to the systems level or to the organizational level, that's one aspect. How do we involve people who are the recipients of care? How do we involve citizens in designing these systems to counter that notion that we're just bestowing this compassion on them?
And it's interesting because for the last number of decades, within the jurisdiction that we're located, patients have had the right to access, say, their records. And this conversation hasn't come up, well, it might have come up years ago, but it seems to have come up more so now that the reality has struck us that patients might actually do that there isn't some cumbersome convoluted process that might be expensive to actually get access to that. And to be honest, our research here has shown that more than half of our patients didn't even know they had the right to access their information. That's very interesting to me as well, Allison, about sort of balancing that power piece out a bit more, even though in theory we've had it around for a while, this idea, but technology seems to be the thing that is the driver of creating a more balanced approach to that.
And I think one of the things it emphasizes for me is enacting of this. It's not just about legislation, it's the courage for compassion. And that compassion, even from an organizational level, requires people to embrace it and say, this is how we're going to behave. Not because we're required to do it, but because it's the right thing to do for ourselves and our patients. So that commitment to saying we're going to be a compassionate organization from a digital perspective, Allison, is something that you've emphasized over and over again in our conversations. But I think this is a really important piece, not only the courage of the individuals, the relationship, but the institutional courage to act.
I just don't think it will be enough unless we take an organizational approach. I think it'll be too individual. It will miss the fact that it is actually patients' rights within their rights to receive this care. Challenges that we've had, I know today we're also thinking not just about digital compassion, but about the current context of COVID. And when I think about that, it's really highlighted this for me. We can't leave it, as wonderful as many individual clinicians are, we can't leave that burden on their shoulders, because I think that's the recipe for some of the burnout that we're seeing, where people are also having to work in organizations where if there's not that scope to be compassionate, if it's not built in, that's where moral injury can spring up, where you feel like you're constantly trying to stretch yourself to do what you know is right within the confines of our new ways of practicing, including digital. And if you can't easily do that, if you can't help patients, for example, integrate the digital care into the rest of their care, if they're having discontinuous care, or they can't get easy access, or they can't get the translator involved, or they can't, if there are barriers that as a clinician you're experiencing that you can see are wearing away at the compassionate interaction, and you're trying constantly to find workarounds, and your organization isn't aware of it, that's a recipe for burnout. And then self-compassion comes into it, because I think you talked about compassionate care for patients and families, but also self-compassion as we work in these new environments.
I think that's really been highlighted, and I think many of us have experienced that through the pandemic and through COVID care. And I'll share a quick story. Early on, I guess about this time last year, when we started to say to folks they couldn't come into the hospital with their loved ones, we had a situation in our organization where we had a bring your own device solution. Not everybody could communicate with their loved ones. Our foundation stepped up and said, we will provide you with iPads to help with the communication and help clinicians connect patients with their loved ones. So we got these devices, and then there was this paralysis of how do we actually deploy them? How do we do it from an infection control perspective? Nobody really knew what to do. And we actually phoned up some colleagues at another hospital, and they said, infection control, no problem. Just go buy a bunch of Ziploc bags, put them in Ziploc bags, and that'll do it. And infection control said, sure, go ahead and make that happen. We bought out the local store of all the Ziploc bags, and away we went. And a couple of days later, one of my colleagues said to me, I have a family member who's in the hospital, haven't been able to connect with them in several weeks in person. Would really love to talk with them. And sure enough, we connected, the technology was there. And a daughter got to talk to her mother, and that hadn't happened in weeks. And all around, I think that helps to relieve a lot of moral distress that everybody experiences.
Maybe one of the supercharged things about this time too is that many of us you mentioned that colleague was a health provider, and many of us are experiencing that dual perspective of receiving care this way and trying to deliver care this way. My mom is in a long-term care facility and had many experiences over the course of the pandemic of not being able to see her and standing on the driveway at the base of her window, while calling her on FaceTime, but she can't quite understand FaceTime. So I had to stand there and just everyone kind of working around and just desperately seeking connection in some cases. So I think we all get it, how important that is for patients and families.
You're bringing up stories for me, Allison, of trying to do a virtual bridal shower with my 94-year-old grandmother through a window of trying to show her how to use, I think it was Zoom or something like that, which ended up being this very fantastic and amazing new thing. She hadn't seen anything quite like this before. And so that was actually a source of an exciting day, in addition to being connected with everyone, seeing a PowerPoint via Zoom with photos and years gone by of us gathering face to face.
I know we've also wanted to expand the definition of compassion away just from the affective, but it is amazing the amount of emotion that you can experience virtually. Like there are people, I was just talking to somebody today and we were like, can you believe we've never met in person? Because we've established a whole relationship over the course of the year and love working together. And I've had therapeutic new connections and it is a marvel.
That's funny. I met someone for the first time and I keep saying real life, but in person, that I'd only met on a screen. And she was so much taller than I thought she was. So little things like that. I was just thinking about, as we move forward in thinking about this concept, but also in the pandemic, things that we're learning now and how they might evolve. I was just thinking back to another personal example where I was fortunate. I worked with a midwife and I had my little one. And the nice thing I always said to others, this is sort of pre-pandemic, but just barely, was that the midwife came to my house the day afterwards. So I didn't have to go somewhere, which would have been a very not fun and stressful endeavor with a day-old baby. And I thought, I can't believe that we've got a healthcare model that requires like new parents and new babies that the day after they've delivered a baby, they have to physically go and wait in a waiting room. And with the advent of more virtual, some of these things, not all of them, they can come to you much more easily. We found with our family physician, who we'd always have to go and see for well baby checkups in person, some of those, he comes to our living room. And it was really nice initially because both myself and my husband could be present at those when typically you'd have to take time off work to be able to go to some of these things. And so I think sort of moving forward, figuring out which of these care interactions that we can do virtually. I don't know if we've quite got that perfect yet, but I think that will be something that we can take the learnings of the pandemic that we were forced to do and decide, well, what was it that worked well and what is not really working well for a virtual interaction. And this is virtual interaction, what we had to discover and identify overnight, let alone what it could be in the future. And so that I see it as likely evolving in the future.
And it's interesting from a healthcare perspective. It's not that we didn't have the technology to do this in the past. People like Allison were knocking on people's doors and saying, hey, we have this thing called virtual care and it'll really help improve the experience. And there were systems barriers, like things like billing codes and so on, that got in the way. But fundamentally, what the pandemic has done is opened up new avenues. And Gillian, and as you say, the interesting thing will be, where do we choose to go from here? Collectively, what will the walls of a hospital mean moving forward? How important are they? And I think that will be a really important part of this conversation moving forward.
Well, I'm really looking forward to this ongoing work. It's so clear that we have so much left to do. I think collaboration is really the key. I think we're in this really new space. That's been one of the most, rewarding things of working with both of you, is gaining new perspectives and kind of discovering this process at such a critical time.
My sense is that we've just scratched the surface, because every time I have one of these conversations with the two of you, and then when we meet with others and have these conversations, there's something else I pick up on, some other nuance to it. So I have a feeling we're going to be working with each other for the next few years at the least.
Well, I certainly hope so. And like every other conversation, I've enjoyed today's conversation immensely. it's opened up new doors, not just from a digital perspective, but in terms of how we talk about caring with and for each other. So thank you very much for that great conversation.
Thanks for joining us today to hear our conversation on digital interventions in mental health. And many thanks to our panel of experts, David Wiljer, Jillian Stredwick, and Allison Crawford. In our next conversation, we explore technologies and their impact on compassionate digital care with behavioral scientist Laura DeVoe and doc and scientist Amal Verma. Thanks for listening, and join our next conversation on good tech, compassionate healthcare. AMS works to advance a Canadian healthcare system through innovation and technology while remaining rooted in compassion and our medical history. They convene networks, develop leaders, and fund crucial activities in medical history, healthcare research, education, and clinical practice. Their work helps improve care for all Canadians. For more information, visit amshealthcare.ca to access their wealth of resources and view their funding opportunities. AMS Healthcare has recently published a best-selling book, Without Compassion, There Is No Healthcare, available wherever you buy your books. A series of articles based on this book are available on healthydebate.ca.
This podcast was produced by Michael McDonnell, music by Carlo Cruz.